Dr. Fisk.
Mr. Chairman and distinguished members of the committee, thank you for inviting me to discuss Medicare Advantage private fee-for-service plans. I am Dr. Al Fisk, Medical Director of the Everett Clinic. The Everett Clinic serves more than 250,000 patients throughout Snohomish County, Washington, which is 30 miles north of Seattle. The Everett Clinic is a physician-owned group practice that has been operating for more than 80 years. We have more than 270 physicians and offer 40 diverse specialty services. We have received national recognition for our innovative approaches to patient care and medicine. For example, we just received the 2007 Acclaim Award for Quality, which is the most prestigious award presented by the American Medical Group Association. Medicare is a subject that concerns us deeply. We serve more than 20,000 Medicare patients, and the number is growing rapidly. Last year, we lost more than $7.5 million on Medicare. We need to find a sustainable model that will allow us to meet our ethical obligation to care for all those Medicare patients who choose to seek care with us. A portion of our losses can be traced directly to private fee-for-service plans. Since the private fee-for-service plans was the most rapidly growing part of our Medicare business, it became clear to us that we could not afford to continue to offer care under this program. So last fall, we informed 1,400 patients that beginning in January of 2009, we would no longer accept private fee-for-service plans. We encouraged these patients to enroll instead in managed Medicare Advantage plans. The decision to curtail the program led to increased communication with our patients. We openly shared our dilemma with the patients and our reasoning for curtailing the program. In addition to written material, we also held workshops attended by more than 400 patients. We laid the rationale for our decision on the table and shared the economics in a very transparent manner. We explained that we were losing money on private fee-for-service plans. The feedback we received was reassuring. Patients understood why we needed to make the change. They had no idea that their program, if allowed to grow unchecked, would ultimately threaten the economic health of the clinic and make it impossible to continue to provide the best possible care to our patients. They were very surprised to learn that the program did not cover its cost. Economics are important, but the problem here extends far beyond the financial burden that we have experienced. Among our core values is to do what is right for every patient. This means delivering coordinated care and promoting health and wellness. Candidly, this approach is difficult with private fee-for-service plans. Efficient, effective health care is provided when the primary care physicians and specialists consult with each other on an ongoing basis, view the same medical histories, and coordinate treatment plans. Coordinated care ensures that effective disease management and preventative care can be delivered to each and every patient. This approach benefits the patient and ultimately saves money for the payer. Give us the tools and the resources to provide coordinated care, and you will have a program that provides better outcomes at lower costs. The system must be structured so patients can receive both preventative care and optimal management of chronic disease. In the current reality, where private fee-for-service plans can deem providers to be part of their network, none of the increased funding over traditional Medicare is shared with providers, which makes it difficult for us to sustain these needed cost-saving services. In addition, unlike the Medicare Advantage HMO and PPO plans that we participate with, the private fee-for-service plans do not share cost of care and quality information with providers. It makes no sense to structure a Medicare plan that provides additional funding only to health plans, not to providers, and does not support improving quality while managing the cost of care. Thank you very much for your time. I am happy to answer questions.
Dr. Fisk, you testified that your experience with private fee-for-service plans on care coordination has been abysmal. Care coordination is obviously very important for patients with chronic conditions like diabetes and heart disease, and quite frankly, an advantage of having people in Medicare Advantage. Would you elaborate on how private fee-for-service plans differ from other Medicare Advantage plans in the term of patient care?
Yes, Senator, I think that the private fee-for-service plans differ in two ways that fail to support coordinated care. First of all, the other Medicare Advantage HMO and PPO plans, since they have to contract with us, they share some of their increased funding that they receive over fee-for-service Medicare with us, so we can begin to afford to provide these extra services. And secondly, the HMO and PPO plans share quality information with us and share cost of care information with us so that we can learn to perform better. Whereas the private fee-for-service plans pay us exactly the fee-for-service rate, none of that extra funding, and they don't share any quality or cost of care information with us.
Senator Cantwell.
Thank you, Mr. Chairman. And Dr. Fisk, thank you for traveling here from the Pacific Northwest. Are you seeing other providers in the region making the same decision that you've made and not seeing fee-for-service?
Yes, there are several that are doing this. I mean, for example, the Polyclinic in Seattle has done the same thing, and there are a number, even outside the state, that have contacted us to understand the process that we've gone through of giving patients 15 months, and so I know there's a lot of organized groups that are thinking and will be doing this in the future.
And could you elaborate? I know Senator Grassley asked you about this issue of coordinated care, but could you give us a specific example of how that impacts the Everett Clinic, or an example of a certain type of care that ends up costing more to the system because you don't have that continuity?
First of all, we treat all our patients the same, so even if they're in a private fee-for-service plan, we're not going to treat them differently. It's just a question of figuring out a way to afford to do what's right. Examples would be that we have a hospital coach, a nurse that visits every patient as they're about to leave the hospital to make sure they understand their diagnosis and understand what the medicines they're on, and then make sure they have a follow-up appointment with their primary care physician. Another example is we have nurse case managers for the most complex sick patients to try to coordinate their care optimally. Another example is that we have multidisciplinary teams of physicians and nurses and other individuals that work on specific diseases like diabetes or coronary disease or asthma to figure out how to improve our quality. And, you know, that all costs us money. And then last of all, we have a dedicated team of physicians and nurse practitioners that cares for our patients that are in skilled nursing facilities, because those people these days are pretty ill. And on that alone, we lose $200,000 annually. So
is that, not to interrupt, but is that where you see the biggest cost if you had to say where across the board? Is it in the elderly and nursing care?
Well, that's just one. I mean, all these, I mean, I think the problem is, as you well know, that, Medicare in the state of Washington pays maybe 60% of commercial payment for taking care of the most complex sick patients, and it's hard to make it pencil out, and that's why we appreciate the Medicare Advantage HMO and PPO plans, because they share some of that increased funding with us.